This is Dr. Paisus Dubey, and you are watching Concept-Based Dentistry Lectures. Today, we are going to discuss local anesthetics. Most of the local anesthetics that we use in our clinics is tertiary MI, and except for few like prilocaine or hexalcaine, these are not tertiary amines and they are rather secondary amines. And what does a tertiary amine and a secondary amine means is clearly depicted by this picture, where the first one is having a nitrogen, that is the amine group, having a carbon this side, another carbon group this side, that is shown by R, and is bonded to hydrogen on the other end. That is three of its bond. It has three bonds in total, and among two of which is bonded through carbon atoms, and one is bonded to hydrogen. This is secondary amine, where the nitrogen is bonded to two carbon atoms at the same time. But in tertiary amine, there is the nitrogen is in bond with three carbon atoms at the same time. This is not up to just this, it is further followed by a benzene ring, just like it is shown above. Now we are coming to few of the properties of local anesthetic molecules. One of the property of local anesthetic molecules is that they are empipathic compounds. And what does empipathic means? That it has both a hydrophilic end and has a hydrophobic part too. Hydrophilic obviously means water loving, and hydrophobic means water hating. The second property is that almost all of the local anesthetics are weak base. That is, if they are in a somewhat acidic condition or medium, then they will dissociate to form salts. And that is an important concept that will make us understand the mechanism of action of these local anesthetics more easily. We'll come to the mechanism of action later on. Property any further, we will discuss the structure of a typical local anesthetic in more detail. This is what a typical local anesthetic molecule would look like. So here comes the division. There is generally a elongated chain, and that is the carbon atoms. In chains can be 1, 2, 3 or multiple carbon atoms depending upon the local anesthetic. And this one is called as intermediate chain. This one comprising of the hydrophilic end, and this one is the hydrophobic end. So basically, as we are seeing in the structure, the hydrophilic and the hydrophobic ends are most of the time at opposite ends. And further, as we can see, that the hydrophobic end is the bulkier or the bulky portion of the compound, the molecule. The hydrophilic is comprising of the smaller part of the molecule rather. And this end, the hydrophilic one, is a derivative of either ethyl alcohol, that is the amine group, or the amino group is a derivative of ethyl alcohol, or is coming from the acids like the COO group, and this is the OH group, that is the acetic acid. One point important here to be noted is that those local anesthetics that don't have a hydrophilic part, rather they are not suited for injections. As if you are, suppose this is the tissue and we are giving this injection, so we don't want the local anesthetic to cross this surface membrane, say dermis or epidermis, or any other membranous structure. We are depositing it directly into the tissue part, and that is comprising of tissue fluid basically. So mm, to make it easy for the local anesthetic to be well miscible or absorbed into this extracellular fluid in there or the tissue fluid, it has to have a rather lipophilic end, or else it won't be miscible into this tissue fluid. And that makes the use of the all those local anesthetics that lack a hydrophilic end and rather have only this hydrophobic end, they are rather used widely on surface structures or the membranes or the skin, where they uh, can cross then the, the membranous structures easily due to their lipophobic or hydro lipophilic and hydrophobic nature. So what lipophilic compounds do is that are readily permeable or permeate through the lipid protein bilayer structure of the cell membrane or rather plasma membrane. So to cross any such uh, plasma membrane of the cells, when we are directly applying on the extra outer side of the cells or the dermis, what epidermis consists of is layer of cells, right? So to cross this layer, they have to go through each of the cells. So to be readily get inside the tissue or cross these epidermal cells, they have to be lipophilic or hydrophobic. Those are chemicals that are hydrophobic are liable to be lipophilic, and vice versa is true also. So all those anesthetic agents that lack a hydrophilic end but only has a hydrophobic end, they are more used as a topical local anesthetic, won't act well as a injectable local anesthetic. The second point, that is they are weak bases, means that as I've already told you guys that in case of any acidic environment, it would have a acid-base reaction and form salts. Third point that I'd like to note here is that they are poorly soluble in water. Poorly soluble in water is the reason because this hydrophobic end is rather more bulky and takes the maximum part or the percentage of the overall molecular structure of this, and this is even this R or the carbon group, even this is hydrophobic. Only this one remains hydrophilic because it would have a charge. Nitrogen having a negative charge is making this thing more polar, and that is, and we know the general rule that like dissolves like, that polar compounds like amine group having a charge will uh, be readily miscible to water molecule, and likely the hydrophobic or the lipophilic compounds will get readily miscible to lipophobic compounds or molecules accordingly. So they are poorly soluble in water, and it is even more poorly soluble if this is present and this is absent. The fourth point here is that they are unstable compounds, and not just unstable or sensitive to pH, or even they can react to air, or they can disintegrate in presence of air and form some other compound, so that their action won't remain the same as a local anesthetic is supposed to be. Now questions might arise that how we are able to use it when they are so much unstable, and even there is air molecules that can get inside the bottles or the capsules or compules that is containing LA. So the answer to this is, once we use it as in salt forms, so suppose it is not just the lignocaine, for example, that we are using for injection purpose, rather it is used as lignocaine hydrochloride HCl. That lignocaine HCl is not an acid, but rather it is salt. The salt form is called as lignocaine hydrochloride, or whatever the local anesthetic be. Suppose X, and there is the salt form, it would be X hydrochloride, and this makes it more soluble to water. That is, the solubility problem would be resolved with this, and even it makes it more soluble. If we are getting this jar or container where there is local anesthetic, it is not in its pure or weak basic form, rather it is the salt or the reaction product of this La with some acid, where and along with it sterile water is also added as a medium. And besides this, there are many more compounds that are added. It can be antifungal, can be an vasoconstrictor or vasopressor agent, and few others that we are going to discuss very soon. Now we are coming to the classification of local anesthetics. The local anesthetics can be either divided into ester form or amide form. A local anesthetic can be amide in nature and ester in nature. Now, what does amide and ester means? Are they totally amide or are they totally ester? If it was true, then there won't be this coming, because this is a salt. So it is ester and amide doesn't make salt. So coming back to the molecular structure, suppose this was the structure, and this is the carbon atom which we were showing as R previously here. This R obviously is a carbon atom, maybe one or maybe more. So we are just removing this to prevent any confusion. This is R, what I've drawn here. So whatever be the valency, I'm not going into the other bonds and details. So what we are seeing here is the CeOR group, and there is carbon atom, and there is the amide group. And this of course is a tertiary amine because 3 of the carbons are attached to the nitrogen. So the COO group here resembles of ester. This one COO group is an ester group. So COOR makes an ester, COOH makes an acid, as you know from the biochemistry of the chemistry itself. So what is there in the intermediate chain will signify or classify the La, if it is an ester or is it an amide. So this one being ester example. The next we will be drawing a amide. So the NaCO, this part being amide group, and this is different from that of the ester group here. So this being amide, and this being ester, and this is just there's nothing. So this is how we decide whether the La is an ester or amide. And what is the significance of ester and amide we are going to discuss. The ester La that are ester in nature or having the intermediate chain that is containing ester are readily metabolized into its metabolic products. So this directly affects the duration or of action of the particular local anesthetic, whereas the amide local anesthetics will have a longer duration of action, since because they are not readily metabolized. The ester compounds are metabolized into the plasma itself. The plasma are having molecules that will break the ester, but the amide is generally broken into the liver. Enzymes in the liver will be acting on the amides and will be able to metabolize them, whereas the esters are already metabolized into plasma and quickly excreted into the urine in its metabolic or metabolite form. And whereas the amide ones are somewhat metabolized into the liver, and most part, or suppose I'm just giving you an estimate, about 70% or most of the percentage of the amide local anesthetics are excreted again to the urine, and that is unchanged, not metabolized. 70% or most of the part of the amide local anesthetics are excreted unchanged or unmetabolized into the urine. And how does suppose for an example, there's a classic example here. Cocaine is an ester local anesthetic, and its duration of action isn't very long, so it is hydrolyzed into plasma in just few minutes. Whereas there's one more compound, procainamide, that is an amide, as you can already figure out by the name, the procainamide. So this amide, the chemical structure being the same except for the intermediate group is changed, and in clinical efficacy, as we have monitored, this is only it is seen that the 10% of procainamide is hydrolyzed in a complete day. So you can see here that 10% is only the 10% of the drug is metabolized in one day, and whereas in ester form it is completely metabolized within few minutes. So that makes a huge difference upon the mechanism of action and the duration of action as well. Many of the students initially get confused easily that how should they remember whether a given local anesthetic is amide or an ester, and this comprises of an important question as well in the boards or the entrance exams. And there's this trick that whenever you are suppose finding a local anesthetic name, suppose lidocaine, and then there is cocaine, and there is prilocaine, there is tetracaine. There are things that are common and similar and dissimilar among these. The first one I'd like to point out is lidocaine has I twice, Lidocaine, so it is having I twice. Cocaine is Cocaine, so it is having I only once, whereas prilocaine again is having I twice, and tetracaine is having I once. So amide, AMIDE, it has I, whereas ester has no I. So you can remember the group having I, and the local anesthetic that is having 2I will be amide. Because prilocaine has 2I and it will be amide. Those are local anesthetics that have only one I or no I will be ester. So lidocaine, I is coming twice, it is amide. Prilocaine, I coming twice, amide. It applies universally on almost all the local anesthetics. Whereas tetracaine has no I, it is an ester. And even it applies to the procainamide also. It is in amide form, it is now having 2I, whereas in procaine form it has just 1I. There's one more classical question, like the question is like when there is an acidic condition, or suppose an information is going somewhere in the intraorally or any part of body where you are supposed to deliver local anesthetic, and why the local anesthetic doesn't work in that particular infected region or inflammation or purulent area, or where there is an exudate. All these conditions I have just now mentioned are acidic environment. These conditions like acute inflammation, acute inflammatory condition have acidic environment around them. So that is the reason when LA is once deposited into that acidic area, it will get readily metabolized into its active form, and once in active form, that is it will split into ionic form, and that is more polar, and polar will easily dissolve into the tissue fluid around it. But since we know that the local anesthetic needs to get into the uh, exoplasm, or they need to cross the exoplasmic membrane so that they can act from inside. For now, just uh, information purpose, you just keep in mind that local anesthetics act from inside the exoplasm, or they have to cross the exoplasmic membrane to act or perform their action. So once into the tissue, they are already dissociated into the tissue fluid into its active form, that is more polar or hydrophilic, that won't cross the hydrophobic membrane easily. So that is the reason, since because they are not entering the exoplasm, they won't action or act. So that is the reason why in acidic environments LA deposited, in spite of in huge amount, it won't act very well, or the efficacy will be reduced further. And just for the value purpose or your information, the pH of normal tissue is generally seen around 7.4. For normal tissue, the pH is 7.4, and as seen in acidic conditions, the pH turns as low as 5 to 6. So we also know that vasopressors or vasoconstrictors are also added to local anesthetic bottles, and the reason is that to prolong, the main reason is to prolong the action of the local anesthetic, and to also prevent the systemic toxicity, also to mm, get a clear field, because the vasoconstrictors will act on the capillaries in the local area, and the bleeding, if any, will be stopped by the action of local vasoconstrictors, and you can get a clearer field to work on while doing surgeries. And with the third point, actually, why vasoconstrictors are used. First one is to increase the duration of action. This is because the local capillaries are constricted, or even the venues that are draining the blood from this area are constricted somewhat. So the LA doesn't diffuse so easily, and rather stays into this particular area. And even the less it is absorbed or drained into the venous blood, the less it is readily getting into the systemic circulation, and the lesser is the systemic toxicity. The third point is to get a clearer field. So now we have known that the vasocompressors are why they are needed to be added to the local anesthetics, and what are the, this is the pros of why they are needed, and there are certain cons, that is adverse effects, or how does it adversely affect the local anesthetic. Mm. So adding a vasoconstrictor would again decrease the pH that it vasocompressors the constrictors. Vasopressors will decrease the pH of the overall liquid, that is the local anesthetic liquid. And again, the vasopressors or the vasoconstrictors are not stable themselves. We have already discussed that the local anesthetics are not stable, or discussed minutes ago that the vasocompressors and the local anesthetics are less stable. And now we are getting to know that even the vasopressors that are added to the local anesthetics are also less stable, and to stabilize it, we need to keep the pH low, and to do that, we add acid or acidic molecules to local anesthetics, so as this vasocompressor is more stable, and making it more stable will eventually end with the local anesthetics, the main component, being even severely unstable. So the data states that those LA bottles not having epinephrine have a pH at around 6.5, and those LAs that have epinephrine or a vasopressor is having a pH of around 3.5. So it even decreases the pH, and this decrease in pH also is irritating to the tissues that are injected with the local anesthetic, and it brings the discomfort to the patient. And that is why, while injecting local anesthetics, we sometimes can get complaints from the patient that it is or they are getting the burning sensation. So if asked in exams, you can really now tell that why during injection of local anesthetic the patients feel burning sensation. Now if someone says that, what if we are elevating the pH, or we are alkalinizing the local anesthetic solution, uh, adding or more alkalinity to the LA will speed up its action, or the onset would be rather more quick. The more quickly the patient will feel the numbness. That would also enhance its effectiveness or the efficacy. And this point, that is the burning sensation, we won't get the burning sensation here, and that's why the local anesthetic injection would be more comfortable. But again, as the pros is there would be cons or the adverse effects. The adverse effect is that, again, as you know, it will make the local anesthetic solution even less stable. And what occurs if the local anesthetic component of the local anesthetic solution gets less unstable, it will ultimately get precipitated, or it will precipitate out of the overall local anesthetic solution.